I'm Daniel Levine, and this is the Bio Report.
Immune checkpoint inhibitors are transforming cancer care, but still have low response rates in most solid tumors. When cancer spreads to the liver, it can render immunotherapies ineffective because of the large number of immune-suppressive macrophages that are present there. Teclison has developed platform technology that chokes off tumors and activates the immune system against the cancer. The company said its technology can significantly enhance the therapeutic benefit of immunotherapies and can be leveraged to treat nearly all solid tumors. We spoke to Ray Lee, founder and chief medical officer of Teclison, about the company's platform technology, its lead therapeutic candidate, and how it can trigger a systemic immune response. Ray, thanks for joining us.
Yeah, thank you.
We're going to talk about liver tumors, Teclison, and its efforts to develop a new treatment modality for aggressive tumors in the liver. I'd like to start with you, though. You were an oncologist. You were doing research at VCU, Macy Cancer Center, and you left that to go to work in the pharmaceutical industry. Why is that?
First, thank you for the invitation. So I like to start with my career goal. So I've been medical oncology, and the most important, I want to be a physician scientist. So the beauty of being a physician scientist is that you'll be able to do two things together. One, of course, is as a physician and oncology, I treat a cancer patient. The other, as a scientist, and I also run a laboratory. So I have this as an opportunity to identify what is the most important thing and the patient care the most, and then identify what is a medical need or the problem, and then come back to work in my own laboratory and trying to solve it. So, and then if you ask what is the cancer patients wants, and it's pretty simple. They want an effective therapy, then also want a less toxicity, and then with a good quality of life, of course. So that has been the main focus of my research. And then I've been working in the university for almost 10 years, and that has been my goal. And then I do believe I identify something which is a work in a very selected way, and just working on the tumor, and I'll be happy to discuss it later. But I was ready to push this forward and see whether I can further develop it. And then I realized a problem. So that is why I decided to join the industry to learn how to do a drug development. And I work in the two major pharma, Merck and Roche, two of the very large international corporations. So in Merck, I was able to run the phase 3 registration study and then do the NDA filing. That gave me the opportunity to see how the drug was able to go through the FDA approval and eventually launch in the market. In Roche, and I have the opportunity to get a FDA designated breakthrough therapy designation, which is a so-called a fast track type of approach. And then we can get using the shortest time frame to get FDA approval. So these two unique experiences really set me up and then help my future career when I'm ready to develop my own drug.
The idea for what became Teclison started at VCU for you. What happened? How did it come about?
Yeah, so when I work in the major pharma, my project or the drug and we developed in the VCU did not stop. It's continued to move along, and with the help of one of my close friends, and who is not a clinician but is an expert in preclinical drug development. So we worked together, and he carried the drug, eventually get to the FDA IND approval, so it's ready for the drug to be launched in the clinical trial. And this is also perfect timing for me because at that time I finished my Roche's assignment, and basically is get the drug into a cellular approval. So I was able to leave Roche at that point, and then set up this company, Teclison. And then so we have been working closely together and get the drug into the current situation. And we're currently in phase 2 clinical development. So everything, the timing turned out to be great. And then we're happy to where we are right now.
Your lead experimental candidate is in development for colorectal and liver cancers, among others. How big a problem do these represent today?
Yeah, these two, and then these are so-called the gastrointestinal or GI malignancy, are actually very important in the oncology territory. I will separate these two to get, and then, for example, colorectal cancer. Every year there is over 150,000 new cases was diagnosed in the U.S. And then 55,000 people died of this colorectal cancer every year. And so it's a very important, as number 2 cancer-related mortality. And for liver cancer, this is also a very important cancer. And every year there's 38,000 new cases and about 30,000 deaths in the U.S. So you can see, and both cancer, quite a lot of people actually succumb to either of the disease. And then so far there's treatment, of course, but there's still a lot of patients unfortunately died of these two cancers. So there's a significant unmet medical need in either one of them.
Well, what are the standards of care today, and what are the prognosis for outcomes?
The conventional therapy for cancer, if you talk about the local regional therapy, and that's surgery and radiation, but once it goes to advanced or systemic involvement, and then it's chemotherapy. Chemotherapy has been used for 30, 40 years. And then, obviously, I don't need to say too much about that. But the toxicity or the side effect is what bothers the cancer patient. And then the last 10, 20 years, we began to develop a so-called targeted therapy, and then used for certain kind of a tumor with a specific mutation. So the target therapy was directly to those mutated cancer. And then the last 10 years has the year for the immunotherapy. And then so this is a new darling for the new oncology treatment. And then that has been the major thing in the last several years. And then people are trying very hard. And there's some very good successful example, including like our previous president, Jimmy Carter, who has advanced the melanoma and then actually got cured and almost got cured by the immunotherapy. That's how powerful it is. So we're really trying to see whether there's any better way to improve the immunotherapy, which certainly has some limitation as well.
The immunotherapies have not had a great success rate to date in colorectal cancer or liver cancer for that matter. Why is that?
Yeah, these two cancer, or the majority of the gastrointestinal cancer, they have the common feature, that is they have a liver involvement. And then for most of you who may not aware, liver is actually a very important organ. And then one of the key feature is when we eat things and then your food that get digested in the GI tract, the blood flow coming from the bowel and then move to the liver. So liver is the first organ after the food is digested. So you can imagine, and when we eat things and the food is actually foreign material for the body, So actually our body doesn't develop any kind of allergic reaction. So why is that? And this is because the liver is it's a so-called a very high immune tolerant. So they have to cope with and suppress the immune system. And so when the cancer spread to the liver, and then they were sort of like in an environment that is a highly immune tolerant. So under this kind of situation, I like to use this analogy. So the liver is a kind of the environment is a kind of a like a brick wall or shelf, and just like an egg, and then actually protect the cancer's tumor inside of the liver. So that is why when you give immunotherapy and the cancer inside of the liver constantly is not working very well. And then you need to identify some way to like a kind of a break. This is a shelf or the brick wall. And then in order for the immunotherapy to work.
Teclison is pursuing a treatment approach called TATE. This is an acronym. What does TATE stand for, and how does it work?
TATE stands for the transarterial TEC-001 embolization. TEC-001 is the compound we're currently developing. And then the way we do this is by injecting the drug into the tumor feeding artery. So the drug is going to distribute it evenly in all the tumor. And then the drug, if you just do this way, the drug actually does not have any activity. And then you need something else. And then it's kind of you trigger and then to make the drug become activated. And then we use this, a procedure which has been used for over 30 or 40 years, called for the liver cancer. It's called the transarterial embolization. Basically, what the doctor did is blocking the tumor vessel and shut down the tumor blood flow. So the tumor, when it doesn't have a blood flow, they will lack oxygen. So, and then the lack of oxygen is provide the perfect environment for our drug to be activated, and then become extremely potent and causing this generated things is called a free radical that is able to break the tumor into very tiny small pieces. So the beauty for this approach is first, the drug is giving in directly into the tumor, and then even the drug is distributed like a leak into outside, like in other part of liver or even in systemic organ, the drug has no activity. So this is a prodrug. We call this the co-prodrug, has no activity whatsoever, and then the rest of the body, not in the tumor, would not be damaged. So this is a really contribute the safety profile of our drug, and then that is why we're currently in phase 2 study, and the majority of the patient tolerate our therapy without any trouble at all. Patient will maintain a great quality of life. And then that's also one of the major beauty. And this is what I called in the beginning, I mentioned about how you're going to deliver the drug specifically or selectively only in the tumor. And because the drug even goes outside, it's not activated, so there's no toxicity. And it's the perfect way I like to achieve and to have a great quality of life for the patient by the lack of the toxicity.
Is this general approach unique to gastrointestinal cancers, or is this something that could be broadened to treat other types of cancers?
That's a very good question. We start with liver cancer, and that's because of this procedure. It has been used as a standard care for liver cancer, but certainly it can be applied for all the cancer spreading to the liver. We talk about gastrointestinal cancer for several reasons, and then because the gastrointestinal cancer has the highest chances to spread to liver. And then you talk about other solid tumor, like the most common lung cancer or women's breast cancer. They also has a very high chances to go to liver. And so, for example, for lung cancer, it's about 40% of the advanced stage, and cancer will spread to the liver. For breast cancer, it's also around 30%. So the chances is not as high as a gastrointestinal cancer, but it's still a very good population.
One of the effects of this treatment approach is that it actually triggers a systemic immune response. Can you explain how it does that?
Yeah, this is exactly the beauty of our design. And then I mentioned about the drug as a prodrug. It doesn't have activity, but once it's active on the hypoxia, it generates a free radical to kill the tumor into by breaking the tumor into very small, tiny pieces. And then this is a process is called necrosis. This is it's a type of a so-called immunogenic cell death. That means the tumor necrosis will trigger very strong inflammatory reaction, attract the so-called antigen presenting cell, and then kind of boost the body to generate anti-tumor immunity. So the necrotic tumor essentially is like a therapeutic vaccine. And then the beauty is that it's your own tumor's vaccine. And then you don't need to have an extra shot, but just by doing this is a TAPE procedure, you convert your liver tumor into a therapeutic vaccine to boost anti-tumor immunity. So this is how our drug is distinguished from the conventional standard chemotherapy. Because it's a chemotherapy or target agent, and they induce a different type of a cell death. Scientific name is called apoptosis. It's not immunogenic. So basically, is the conventional chemotherapy would not be able to convert the tumor into a therapeutic vaccine. So even though the people combine the standard chemo with immunotherapy, but it was not able to enhance the immunotherapy efficacy. And then you may also wondering how this is able to break. This is the liver's barrier, such as the shelf or the brick wall I just mentioned. And this is because this is a unique wall formed by the liver to prevent the immune system. It's formed by a type of special cells called the macrophage. And then chemotherapy cannot kill the macrophage, but our drug and basically is working for the necrosis mechanism, is able to kill these macrophages as well. So that is why our drug is able to break this is a brick wall or the immune barrier. And then so our drug is able to work in make the immunotherapy works better.
As you look at this in combination with other immunotherapies like checkpoint inhibitors, is there a synergistic effect in doing that?
Yes, this is a very strong synergistic fact. Let me clarify a concept for immunotherapy. Immunotherapy drug, and for example, you probably heard about the two most important immune checkpoint inhibitor, either Keytruda or Opdivo. And these are two drugs. They does not target the tumor directly. Their target is actually a special type of an immune cell. It's called the T lymphocyte. And they have to activate the T lymphocyte, and then it is the T lymphocyte killing the tumor, not the drug itself target the tumor directly. So after our TAPE therapy, I mentioned about we convert our therapy convert the tumor into a therapeutic vaccine. So basically, is the body actually generate a more anti-tumor T cell, and then these T cells will be activated by those immune checkpoint inhibitor, and then so that is why our therapy has a synergistic. That means it's 1 plus 1 is bigger than 2. And then so we'll be able to enhance the immunotherapy efficacy.
What's known about the safety and efficacy of TEC-001 from studies that have been done to date?
Yeah, so we have conduct phase 2 study, and then I use liver cancer and colorectal cancer as example. So, for example, we have treated a patient with a very advanced liver cancer, which has a very, I would say, almost a huge tumor bigger than 14 centimeter. So you can imagine 14 centimeter. It's almost twice as a baseball size. Okay, so this is a big tumor, and this guy also have a lung. The tumor also spread to the lung. What we did is use our TATE therapy to treat the liver lesion, and because the liver lesion and it's a subject to the TATE procedure, and then we successfully killed this is a liver tumor, and give the patient an immune checkpoint inhibitor, and then 3 months afterwards, his lung lesion completely disappeared. That means our therapy is really increase the immunotherapy efficacy, and by probably activating, generating more anti-tumor T cell, and the T cell further enhanced by immune checkpoint inhibitor, so they were able to get rid of the lung lesion and then the liver lesion as well. And if you just give this patient immune checkpoint inhibitor, the response rate as a single agent, and the complete response rate is about 1%. And overall response, including complete plus partial, it's about 15%. And then we get this is a guy almost cured, because this guy remained disease-free for over 40 months, and which is more than 3 years. So I feel extremely happy for this gentleman, because it seems to me he's very close to getting cured. So that's one of the successes example. And then our overall response rate is more than 50% of the patient actually will have a very good outcome with this combination of TATE plus immune checkpoint inhibitor. And then for the colorectal cancer has been extremely difficult, and because it's only about very small population and with high mutation burden. And then, so these patients may have some responses to immune checkpoint inhibitor, but the 95% of patients will have no response at all. And then we focus on those patients who has no response, and then treated with our TATE. And that means we treat the liver lesion, reduce the liver tumor burden, and also convert the liver tumor into a therapeutic vaccine, followed by immune checkpoint inhibitor. We see their survival almost double, and then normally when they have advanced setting, failed 2 lines of the standard chemo, their median survival is only roughly about 6 to 7 months, and our drug is able to achieve almost by at least double. So this is a significant improvement. And then the most important thing is we treat the TATE, the liver lesion, with our TATE, followed by immune checkpoint inhibitor. Colorectal cancer would not have any response to this patient, but then we were happy to see the patient's lung lesion actually get significantly smaller, and then so that's why they also live longer. So we're very happy to see this. Our phase 2 is still ongoing, but there is a few of such kind of very encouraging example, and then that's really give us confidence, and then those patient is going to do well. So that's what we have, and at this point we continue our phase 2 study, but so far we are extremely happy to see the preliminary data and showing a promising results so far.
And what's the development path forward?
The we are conducting 2 phase 2 study combining the TATE with either Keytruda or Opdivo. Those are the 2 most popular FDA-approved immune checkpoint inhibitor. We're conducting 4 different kind of a cancer, including advanced liver, advanced gastric, and then also colorectal cancer, and then we also add a non-small cell lung cancer. So these are the top 4 cancer-related indication, and also the most important cancer-related mortality in the world. So we're aiming to achieve a big impact for the oncology territory, and then focus on these 4 type of cancer, and then if we get any signal, and we would like to move forward for like a phase 3 registration study. And in particular, the study combine our TATE with Keytruda, which is a collaboration with Merck, and then who provide all the Keytruda for our trial. And then we're happy to have a work with Merck. And then so suddenly, if we move forward, and then further collaboration with Merck, and will be anticipated.
Teclison raised $5.9 million in financing in February. In terms of cancer drug development, that's not a lot of money. How are you using it, and how far will it take you?
Yeah, you are absolutely right. The amount of money is not enough for carry us all the way to the drug approval. But we're raising this money as a catalyst. And in other words, we use this money to conduct the phase 2 study I just talked about. And then we're try to achieve a certain kind of a important milestone, such as our collaboration with Merck. And once we only try to achieve and to a signal that would be able to make the Merck satisfactory and to continue or move to the next stage, which is a phase 3 registration study. So we're not trying to carry all the way with this amount of money, but we carry to a certain critical milestone, and that is why it's sufficient. And also, I like to give a strong attribute and to our team. We have a small team. We're extremely cost effective, and then I'm proud with my team who I recruited from the different kind of a company, and then they're the best of the best, and so we can use a very limited amount of resource to do a lot of things.
Ray Lee, founder and chief medical officer of Teclison. Ray, thanks so much for your time today.
You're very welcome. It's really a pleasure to talk to you.
Thanks for listening. The Bio Report is a production of the Levine Media Group. To automatically download this podcast each week, subscribe to our RSS feed or through iTunes or other podcast manager. To join our mailing list, go to levinemediagroup.com. We'd love to hear from you. If you want to drop us a line or are interested in sponsoring this podcast, send email to danny@levinemediagroup.com. Special thanks to Jonah Levine, who composed our theme music, and the Jonah Levine Collective, which performs it.